Good evening, esteemed colleagues, distinguished guest speakers, moderators, examiners, postgraduate trainees, and members of the Indian Society of Anesthesiologists, Visakhapatnam City Branch. It is my honor as President of ISA Vizag to warmly welcome you all to the inaugural Postgraduates Orientation and Discussion Series on this 20th February 2026. This online session marks a key academic initiative by our branch to empower the next generation of anesthesiologists. We begin with Dr. Nilesh Naphade, a renowned consultant radiologist and anesthesiologist, Secretary Anesthesia Patient Safety Forum, and National Secretary FAMCA. Is delivering the insights on anesthesia for MRI and practical considerations. Moderated by Dr. M. Ramakrishna Reddy sir, Superintendent PM RIMS, GC member ISA National. Welcome sir. And Dr. Prasad Rao, Professor HOD Jim sir. Welcome sir. Dr. Madan Mohan Reddy, Honorable Secretary ISA AP. Welcome sir. And this is followed by Dr. Ashok, a postgraduate from Gayatri Medical College, presenting interpretation of chest X-ray, moderated by Dr. Padmavati ma'am, with examiners Dr. Varprasad sir and JV Praveen sir. Welcome to all. PODS bridges theoretical knowledge with the practical skills essential for postgraduate anesthesia training in India, aligning with competency-based curriculum that emphasize hands-on management and multidisciplinary learning. As anesthesiologists, we navigate complex scenarios like MRI anesthesia, where patient safety amid unique challenges such as magnetic fields and monitoring in paramount expertise, Dr. Naphade will illuminate. Chest X-ray interpretation sharpens our diagnostic acumen, crucial for perioperative decision making and critical care. Let us engage actively, ask probing questions, and contribute to this vibrant discussion. Thank you for joining PODS together. We elevate anesthesia standards in Visakhapatnam and beyond. Welcome to all.
Thank you. So without wasting much time, let us begin the first session. Over to the moderators of the first session, Dr. Ramakrishna Reddy sir, Dr. Prasad Rao sir, and Dr. Madan Mohan Reddy sir.
Thank you, Dr. Praveen. So this is a very good initiative by ISA Visakhapatnam City Branch to have this PODS session. Now this is fourth session. So now I welcome Dr. Nilesh to start his presentation.
Yes. Thank you, sir. Thank you very much. Thank you, respected moderators, organizers and office bearers of ISA Visakhapatnam. And with your permission, I share my screen and start with the presentation without much waste of time and ado. Yeah. So my topic is non-operating room anesthesia, NORA, particularly only focused on MRI suits. I'm not going to include X-ray and CT because MRI is the biggest challenge and a lot of problems with MRI which are not routinely discussed. So I'll start with the usual NORA challenges. These are the challenges which are certainly there in MRI suit, but in almost all NORA areas, these challenges exist. Unfamiliar spaces. We are not used to those places. The anesthesiologist who is posted in the NORA area may not be a regular visitor to that place, and hence you don't know the PowerPoints. You don't know if some monitor suddenly stops. You sometimes don't know whether the oxygen there is replenished, not replenished. So you are unfamiliar with those NORA spaces. Unfamiliar staff and unfamiliar assistants. Unfamiliar staff means we are unfamiliar with those people who are assistants and staff, assistant staffs in MRI, and they are unfamiliar with our requirements. They don't know what exactly anesthesiologists need. And we are used to having assistants in the operating room who understand quickly when we want oxygen, when we want laryngoscope, where is the other laryngoscope kept, and everything they know. Whereas in MRI, you have staff, they don't know you, they don't know what you will need next. There is no central gas pipeline unless it's a government institute or a multi-specialty hospital. Private centers don't have central gas pipelines. The cylinders are unreliable. You don't know whether they are full, when were they replaced, when were they refilled. There is an emergency card, particularly in private standalone MRI centers. Again, each time I will keep on saying that institutional setups are a little different. But yet, even in institutes and multi-specialty hospitals or teaching hospitals, the emergency crash cart has to be evaluated every now and then. It has to be revamped and revisited again and again. Sometimes this does not happen because the MRI center is far away, removed from the operating room, and the anesthesiologists, if not full-time posted in MRI, and sometimes only they are called, then these things remain ignored or unattended. You, as an anesthesiologist, need to be aware of some non-anesthesia, non-clinical prerequisites of an MR room, which I will elaborate on. Very interesting. Very interesting. I'm going to elaborate on a number of things. Like, I'll just give you two examples of, one example is makeup which people wear and come in an MRI, how that impacts the MRI and how MRI impacts that makeup. So there are many such non-clinical, non-anesthesia prerequisites which we need to know. Very narrow and inadequate spaces is another NORA challenge which we have to circumvent or work around. Now, what are the commonest expectations from anesthesiologists or anesthesia in radiology or MR? The most common expectation is to immobilize a patient. Which patients need to be immobilized? There are 4 categories. A small child always fears isolation and fears big machines, and hence it becomes uncooperative and cranky when put into the MRI or a CT scan or any big machine. So this cranky patient who becomes uncooperative needs to be immobilized. Mentally challenged child, a mentally retarded or a special child, or mentally challenged adults. Third is psychiatric adults or psychiatric patients who are unwilling to stay steady. And last is patient is cooperative. Patient understands the responsibility to cooperate, but has extrapyramidal or involuntary movements which is beyond the scope of his or control. These 4 categories are the patients who need to be immobilized. So, if immobilization is the only requirement of the investigation, such patients rarely require suspended respiration or controlled respiration. Everybody will appreciate that making the patient remain still or unmoved is the requirement. Intubation in such cases may not be required. So, if only immobilization is the case, then you don't need to intubate the patient. You can conduct the case on Dexmed alone, or a Dexket combination, or a Ket-Midas combination, or any combination of your choice which you are used to with spontaneous respiration. So these are perfect choices. You can go ahead with these choices even in an MRI, and provided you are constantly observing the patient. Commonest errors in NORA radiology suits are patients are sedated and anesthesiologist sits in the console room. This is very, very common. Patients are not monitored or are inadequately monitored. Oxygen is not administered as a standard protocol in each and every sedated patient. So patient is sedated. Patient is sedated but not oxygenated. Patient becomes hypoxic or apneic, and that goes unidentified because sometimes monitoring is inadequate and you are not there in that room. You are in the anesthesiologist in the console room. Commonest cause of patient loss is poor monitoring. It is not incompetent anesthesiologist. It is not inadequate equipments or gadgets. It is poor monitoring. Monitors being available but not deployed for lack of time, for hurry. Why to connect a monitor for such a short case? Radiologists also sometimes hurry up. Come on, chalo, jaldi karo. This is a 15 minutes, 20 minutes, 30 minutes case. Why you want to connect all these things? Please hurry up. We have to take next case. All these things are the reasons why the patient is poorly monitored. And the statistics is there to prove that commonest cause of patient loss is poor monitoring. This is a picture I have shown as a common prototype layout of an MRI, even a CT scan MRI machine. In these MRI rooms, this is where you have to stand on the backside of the gantry, where the patient's head goes inside and you can observe the patient, maybe talk to the patient, be with the patient and give confidence to the patient. This is the best place to stand. But people say, no, this is very crammed up, I will sit here. So they go and sit in the console. They stabilize the patient, they connect the monitor, or they give the sedation, observe the patient for 5 minutes, and when the scan starts, people go and sit in the console room. This is very common. This is wrong. Never to be done. This can be a good location to stand. This is the best place, in fact, to stand. But this also can be a good place because you are standing next to the patient. You are seeing the chest expansion, breathing, everything. You are looking at the breathing movements of the patient, and you can talk to the patient, see the head end of the patient. This is the best place to stand. Litigations against anesthesiologists from NORA areas are, amongst all the litigations against anesthesiologists, cases from NORA areas are dominating the statistics. So we need to work on reducing the pitfalls or complications or problems in NORA areas. NORA cases are the highest number of cases amongst the cases against anesthesiologists. Now, this is a pictorial depiction of an MRI. Now, there has what is seen in between is the non-metallic connector. You have to use a long tubing with an NRV, and you have to ventilate the patient if the patient is intubated or has a tracheostomy from before. Here, many times patients, the anesthesiologists find it difficult to stand so close to the gantry. They feel worried. Sometimes the anesthesiologists themselves may have a pacemaker, which is not compatible with the MRI. So they stand very close to the, they find it difficult to stand very close to the gantry. In such circumstances, I will recommend that you elongate the tube, put an extension, stand far away. If the space if there is enough space behind the gantry, you can stand far away from the patient, but yet be close to the patient, observe the patient's breathing, observe the ventilation, and factor in the long tube and the dead space that it has created. If the patient is on spontaneous breathing, I will still recommend giving oxygen to the patient by nasal prongs or a venti mask. In fact, this is the place, if the patient is spontaneously breathing and you don't have to ventilate, you don't need to stand behind the gantry. But this is the place where I will recommend the doctor stands and observe the patients throughout the investigation. This is the best place to stand in any eventuality. How the subsequent slides will elaborate. This ventilator is called DuPac Parapac equipment. It's a ventilator. It has pediatric settings also. Adult, child, neonate, infant, everything is there on this. This is the best ventilator because many times what happens is you don't want to stand close to the gantry and give the IPPV by an ambu bag. You can use these kind of ventilators. Refurbished models are also available in various big cities of India. So you can always buy this kind of a ventilator so that the ventilator can be put. This is an MRI compatible ventilator, as you can see. You can take a photograph of this number also if somebody wants to buy. But the patient, if on an ambu bag, can be put on this ventilator, and you can be standing a little away from the patient and take look at the monitors and observe the patient. This is another picture of the same ventilator with a longer tube. What I'm trying to tell you is that the ventilator can be kept far away and the tubing can be connected to the patient. This is a handy ventilator with a long corrugated tubing, and this is available in only 30,000 rupees in India with various vendors. If you have not taken a picture, take a picture of this NewPac Parapac 200D. It's an MRI compatible ventilator available for pediatric, infant, child, and adult. All settings are available. So quite affordable. I would recommend that whether the patient is on IPPV, that is intermittent positive pressure ventilation, or on spontaneous breathing, no case in NORA without oxygen supplementation. Now, if what was said in the above slide is followed as a dictum, claims of negligence against doctors in NORA cases will reduce dramatically. Once again, I am repeating, on IPPV or on spontaneous breathing, make a decision, make a dictum in life, follow it religiously. No case in NORA without oxygen. Always do that and you will be very safe in your career. The MRI machine, I would like to elaborate a little bit on the MRI machine. You should know these words. Now, this is the gantry. The donut into which the patient goes is called as the gantry. And the hole in which the patient travels inside is called as the bore. So you have to use these words when you talk to the radiologists and the technicians. This is the gantry, and the bore is the hole in between, the hole within the donut in which the patient travels inside. Accident in MRI suits have occurred worldwide. The latest death has been as late as in 2025 in New York. where a young man was crushed to death in an MRI suit because of an accident. Now look at this picture. If you can see, if you cannot understand, it's an oxygen cylinder which has got sucked into an MRI machine. Here, a whole ICU bed has got sucked into the machine. A wheelchair has gone into the machine, a monitor, and the stand has also got sucked with the IV stand into the machine. This is because of missile effect and dangerous projectiles. I'm going to elaborate 4 slides on missile effect and dangerous projectiles. This kind of an ICU bed with all its monitors and stand and everything has got sucked into the MRI machine. These are all real pictures. This is not AI. One more case here I will like to explain to everybody is the famous Sao Paulo case. Sao Paulo is a city in Brazil. A person called Leandro Mathia de Novaes. He was a lawyer by profession. He was accompanying his mother for an MRI examination. He was told outside the MRI room that, sir, you need to remove all your metallic objects. Don't take the watch inside. If you have a bunch of keys, keep it out. Are you carrying any metallic objects? This happens in our country very often. People feel that these MRI doctors and the MRI technicians are over smart. They feel they are special. They unnecessarily, what he will know. This lawyer thought in the same thing, in the same lines. He was asked if he was carrying any metallic objects. He said no. But he had carried a concealed gun inside his clothes. Very often the gun is concealed inside his clothes. It was concealed. And he went into the MRI gantry room. He had gone for his mother's MRI examination. And something dramatic happened. When the MRI started, the gun fired into his abdomen. When the MRI magnet became active, the gun fired while the gun was inside his clothes. The bullet went into his abdomen. 15-20 days after this incident, he was struggling for his life. He was in an ICU, but he succumbed. His mother survived, but this young lawyer died in the ICU simply because he had carried a concealed gun and he had not cared to tell the questioners that, look, I have kept everything else, but the gun I am carrying, do I need to keep that also outside? He was belligerent. He was, he felt that these people will not know. But the gun fired. Can you imagine? This is the effect of, this is what I'm going to tell you, 2 effects. Missile effect and dangerous projectile effect. These are universal terms used all over the world. What is a missile effect? Please, all the people listening to me, focus on the words. The missile effect is seen in an MRI room when ferromagnetic metallic objects are pulled into the magnetic field of the MRI scanner with a dangerously high velocity. This effect of ferromagnetic substance being pulled is called missile effect. And the object which is pulled, it becomes a dangerous projectile. This definition is very interesting. Any ferromagnetic object that is forcefully attracted by the incredibly powerful magnet of the MRI machine, causing it to become an airborne, high-speed projectile having a potential to strike people or machines that come in its path, are called dangerous projectiles. In such an unexpected and unpredicted trajectory, these metallic objects fly in an MRI room, that whatever comes in its way, it will bang it. It will bang against it. If it's a patient's head, if it's an attendant's head, it will bang the head of that attendant also and damage and in fact even kill the patient. So missile effect and dangerous projectiles are 2 very important terms. You all need to know what they are. What you are seeing on the screen are all these objects have the potential to become dangerous projectiles. They are all ferromagnetic objects. Now we need to understand MRI zones. There are 4 zones in any MRI center. Every MRI center has got 4 zones, 4 different rooms. Now this is a usual layout of an MRI center. Your hospital, your center, your multi-speciality hospital, government hospital may have a little different design, but always there is a zone 1, zone 2, zone 3 and zone 4. You always enter the zone 1. Zone 1 is the free area where people sit, people come for appointments. The reception counter is located and waiting area. So this is completely safe and outside area. It's called zone 1, free for anybody to come and go. The zone 2 is from where the dangerous area begins. The magnetic effect starts taking charge. Zone 2 is where the patients are held. The next patient is waiting. The patient is given to change. The relatives are told about the removing all metallic objects, metallic belongings. This is the zone 2. Zone 3 is the console room or the control room from where the radiologists or the technicians control the machine. So through a glass, They are seeing the machine and they are seeing the patient. And this is the zone 4 where the actual MRI machine or the magnet within the machine is located. And anesthesiologists have to enter this room. What I was telling is very often patients under anesthesia are in zone 4 and the anesthesiologist prefers to sit in zone 3 because he feels patient is under, I am watching through the glass. If the radiologist is watching through the glass, I will also watch through the glass. I fold my hands and request every anesthesiologist who works in MR, never sit in zone 3, always go and stand in zone 4 next to the patient. As long as you are not wearing dangerous makeup, you are not carrying dangerous ferromagnetic substances, you don't have a pacemaker, you don't have a metallic implant in your body, you are safe to go into zone 4. So if you are MRI safe, always go in zone 4. You will be able to intervene with any emergency arising with the patient and stand next to the patient. It is imperative and record it in your anesthesia notes that you stood with the patient from before anesthesia until the patient was taken out of the zone 4. This is what you need to record on the patient's notes. Now, after zones, we need to understand what are Gauss lines. I suppose some of those who are already working in MRI must be knowing what are Gauss lines. But if you don't know what are Gauss lines, this presentation is the purpose of this presentation is to tell everybody what basic terms about MRI center are. Gauss is an older unit of measuring magnetic flux density, which means the strength of the magnetic field. So more the Gauss, more stronger is the magnetic field. 1 Gauss is 10 raised to minus 4 Tesla or 1 millitesla. What is a 5 Gauss line? It is the boundary within the MRI room beyond which the magnetic field is weak and is considered weak enough for individuals with implanted medical devices and general electronic equipment to be safe. I will show you a photograph. This is a 1.5 Tesla MRI example. I have got this photo because there are lines drawn in this center. I am sure in everybody's hospital, these lines are not drawn. So if you go to your center tomorrow, this 5 Gauss line and the outer line will not be drawn. But you can imagine where the line will be and you need to understand where the lines actually ought to be. This is the 50 Gauss line. What the arrows are showing, that brown thing, the border of that is called as the 50 Gauss line, which means that the impact of the magnetic field within that line is 50 Gauss. Very high magnetic field acting in that area is called 50 Gauss line. And the outer line is called 5 Gauss line. And this 5 Gauss line is also called as the pacemaker safety line. So 5 Gauss, outside 5 Gauss line, any patient with any pacemaker can go and stand. He will not be at harm from the MRI. Any monitoring device can be taken outside the 5 Gauss line. This is actually how the magnetic field, the shape of the magnetic field actually is. But these are how the lines around the MRI can be drawn. Now, this is a pictorial diagram I'm trying to show you. See, the MRI machine is within the white circle. There is another circle around it, which is called as the 50 Gauss line. Is that clear? Now, this is the dangerous. I have shown it in red because this is the dangerous area. The highest impact of the magnetic field of the MRI machine is in the red circle. And the yellow circle outside, the outer border of the yellow circle is 5 Gauss line and so outside that yellow outline, everything is safe. That is the safe area for pacemaker, for any other equipment. That outer border is called as a pacemaker safety line. So always, if you have a pacemaker or you know that a patient's attendant has a pacemaker, he should be standing outside the 5 Gauss line. MRI compatibility. I'm going to dedicate a few slides to MRI compatibility. Very, very important part, most important part for anesthesiologists, because this was a term which is now a little outdated. We used to say whether this thing is MRI compatible or this is not MRI compatible. This term is not used anymore, but because of the habit, people still say whether use words as MRI compatibility. Actually, the 3 words which are now in use are MRI safe, MRI conditional, and MRI unsafe. There is no 4th word. So there is no MRI compatible and MRI uncompatible. It is either MRI safe, MRI conditional, or MRI unsafe. I will elaborate. There are fixed logos. This green color and MR in green is the logo for MRI safe. A red cross, a red no sign on a black font MR is the sign for MRI unsafe. And a yellow colored conical logo, with black alphabets is MRI conditional. If this logo is there, many products which are to be used in MRI have these logos on them, particularly European and American products. They have these logos on them, whether it is MRI safe, MRI unsafe, or MRI conditional. We need to understand what is the meaning of all these three terms. Every anesthesiologist must know. Now, friends, the lower rectangles in which the words are written are the rectangles I have drawn. So this is not a part of the logo. This is the only logo. So your product will have only this logo. This I have put here for you to understand. A green MR means MRI safe. A yellow conical MR means MRI conditional. And a no sign on an MR is MRI unsafe. So this is what I have put. Otherwise, you will see only these logos. Now a list of things which are MRI unsafe. What are the MRI unsafe things? Usual laryngoscopes which we all carry. MRI unsafe. Metal connectors unsafe. Bagels for safe. I will request everybody to switch off your mic, please, because even if somebody else talks in the room, that comes here, that is heard here. So metallic stilettes are unsafe. Oxygen cylinders, Boyle's machines, usual operation theater workstations, regular monitors, MRI unsafe. Syringe pumps, MRI unsafe. ICU beds, stretcher trolleys, wheelchairs, monitor trolleys, ventilator trolleys, and not only that, your metallic watches that you wear on the wrist, they are also MRI unsafe. So you should know whether you are using an MRI safe gadget or no. Tracheostomy tube, the traditional metallic tracheostomy tubes which used to be put, this is a modern, what is called speech prosthesis. The speech prosthesis, many times some patients who have undergone laryngeal surgery, they have a speech prosthesis. These also contains metallic components. The tracheostomy tube is fully metallic, which you are seeing on the screen. But the speech prosthesis, which appears to be silicone or PVC or something like that, but it has metallic components inside. So you need to know whether your patient has a speech prosthesis, a pacemaker, or some other metallic implant. You have to ask. If you don't ask, the radiologist will say, I have given the patient in your custody. I thought you will ask. And if something goes wrong with the patient, you will be party to that offense. Both these are MRI unsafe. This is MRI conditional. Why? Endotracheal tube. Why? Because can you see that metallic spring? So it's a very small spring. But it can be impacted. So this is MRI conditional. What is conditional? What you will have to do if a patient has an endotracheal tube of this type with a inflatable balloon, the pilot balloon outside and the spring, what you can do is these are MRI conditional objects. Means they can be safe if you take some care and caution. What is the care and caution you have to take? Tape the balloon valve at least 3 centimeters away from the MRI FOV. FOV stands for field of vision. So whatever is undergoing the MRI scan, keep it 3 centimeters away from that. So the patient's chest is being examined. Keep the balloon away from 3 centimeters away from the chest. Tape the balloon and the patient's shoulder. Or if that is not possible because the tube, that area, the head face neck or the neck area is being scanned, cut the balloon valve like this. Cut it. Insert a blunt needle in the tubing on the left-hand side. Throw away the right-hand side portion. Blunt needle is to be inserted on the left-hand side tube and seal it with a tape to maintain the cuff inflation so that the tube is sealed. But there is no spring available. So there is no condition, there is no risk with that because that spring is eliminated. What are MRI safe anesthesia machines? They are machines specially designed to operate in an MRI room. They are certified to be safe in MRI environment. They are made from non-ferrous materials which are resistant to magnetic fields. They can never become dangerous projectiles under the influence of magnetic fields. So what are non-ferrous materials? So what are these anesthesia machines, Boyle's machines? What are they made of? They look metallic. They look like metallic, but they are non-ferrous. They are MR safe because they are non-ferrous. So what are those materials? Zinc, copper, lead, aluminium, tin, or alloys. Alloys means mixtures of these metals. If anything made of these metals are non-ferrous, so they are not subjected to the MRI magnetic field. You can ask for these. You don't need to go into the details of what is this anesthesia machine made of and all that, but you have to ask for a MR safe certificate from the vendor from whom you buy. A BPL Penlon Prima 451 machine available in India. BPL machine available in India. This is a MR safe machine. This comes with an MR safe certificate. I'm just giving you examples. There might be more also. I'm just giving you one example of each place. I want to give one scenario to all the listeners. MRI machines are of variable magnetic strengths. 0.3 Tesla, 0.5 Tesla, 1.5 Tesla, sometimes 2 Tesla and 3 Tesla. The more the Tesla, more is the stronger the magnet of that machine. An anesthesia workstation, which is safe in one MRI center, may not be safe in another. I'll tell you what I mean. What happens is all these in southern India, these Aarti scans and this multi-chain of scan centers are there everywhere. So there will be 2 centers in Visakhapatnam itself, 12 centers in Hyderabad, or 2 centers in some other place, and there will be a chain. In the same town, if there are 2-3 MR centers, you are called for a patient in center B, and that day they say that we don't have an anesthesia machine in center B, but we have a patient here in center B. So we have sent for our machine which is in center A. That anesthesia machine is being brought here. Doctor, they will tell you, anesthesiologist, please give anesthesia. We have called for the machine. I want you to know this. You need to be aware whether this machine and that machine, MRI machine, are the same. If the MRI machine in this center is 3 Tesla, and the MRI machine in the other center from where the anesthesia machine is being brought, if that is 3 Tesla, or sorry, 1.5 Tesla, that machine will get sucked into this 3 Tesla machine. So a machine which is suitable for a 1.5 Tesla machine may not be suitable for a 3 Tesla machine. So either if you can switch machines between centers, or in a medical college, what happens is there is an MRI center, the anesthesia machine is bad, not working, workstation is out of order. So you say sometimes we will bring that machine from the operation theater. It is MRI safe. They had told me when I purchased. But you don't know whether that is suitable for 3 Tesla or it is suitable only for 0.3 Tesla when you bought it. If it is suitable for 0.3 Tesla, it is suitable for a weak magnet. If it is brought in a machine, brought in an MRI room with a 3 Tesla MRI machine, the 3 Tesla is a very powerful magnet. It will suck that machine. So you need to be conscious. Discourage shifting of machine from one center to another, or one operation room to another, MRI room and all that. Or if at all that is done, ask somebody to take full responsibility of whether that machine is compatible with the MRI, whether the anesthesia machine is compatible with the MRI machine that you are going to use it with. Also buy the complete set of the anesthesia workstation or Boyle's machine or whatever from one vendor. The anesthesia machine, the circle absorber, vaporizer, everything related to the anesthesia machine should be bought from one vendor. Don't outsource. Don't buy a machine from Boyle's machine from this vendor, a vaporizer from another vendor, a circle absorber from another vendor. Because when you buy the circle absorber, you might forget, or if somebody else buys it for you, you might forget to tell that this circle absorber is going to be fitted on an MRI by Boyle's machine, on a Boyle's machine in the MRI center. So always buy it together and don't separate it. Put it together, keep it together. Otherwise, missile effect and dangerous projectiles can develop in your MRI center. MRI compatible anesthesia machines. I will request everybody to fish out your phones. You might have to take a photograph. I'm going to give you websites where MRI compatible anesthesia machines are available. These are all different websites on which MRI compatible machines can be seen. You can decide. And the last is a machine available for 95,000 rupees, Indian made machine. So take a photograph. Anybody who wants to buy machines, you can take a photograph. Please observe, this is the Draeger. Draeger is a European name. So the name of Draeger always is written as D-R-A-G-E-R, but the website has an E in the name. Please don't consider this as a mistake. It's a correct spelling of the website, D-R-A-E-G-E-R. So this is why I have deliberately highlighted it. Don't presume it to be wrong. MRI compatible monitors. What are MRI compatible monitors? Again, I am giving you websites. Take a photograph. If you want to buy a monitor which is compatible with MRI, these are the people who sell MRI compatible monitors with 3 Tesla MRI compatible, 1.5 Tesla MRI compatible. So please take a photograph if you want. I have given you MRI compatible monitor photographs also. We all know that these are oxygen concentrators. People have used them. But do you know that none of them are MRI friendly? None of them are MRI safe. There is no oxygen concentrator available in the world today which is MRI safe. At least as far as my knowledge goes, there is no MRI safe oxygen concentrator. So if they tell you, okay, we have an MRI oxygen concentrator in the ICU, should I bring it here? Tell them no, it is unlikely to be MRI safe. So first look for whether the oxygen concentrator is MR safe. Most of them are not. Now, do you know that there are MR safe oxygen cylinders? Obviously, our routine oxygen cylinders that we use in operation theaters are not MR safe. They get sucked into the machine. They are ferromagnetic substances. These are aluminum cylinders which are MR friendly, and hence they are called MR safe oxygen cylinders. Now the problem is that please understand that the shoulders are green, not white like our ward cylinder or the jumbo cylinder or the other cylinder that we use, even the machine cylinder, the anesthesia machine cylinders, they have white shoulders. These have green shoulders because they are MRI safe. And these MR safe cylinders are made of aluminium, so they're expensive. A 5-liter cylinder or a 10-liter cylinder costs 55,000 rupees. Now, these are the problems why there are highest number of litigations in MRI patients, because we are not provided with all these things which are essential for and life-saving for our patients. The metallic cylinder cannot be brought, aluminum cylinder cannot be bought. That cannot be brought, this cannot be bought, because 5-liter and 10-liter cylinders are 55,000 rupees. But if you come under the pressure of the MRI center, people running the MRI center, the radiologists, and you try to say that no, oxygen is not required, the patient can go bad. And that is another reason why most of the case litigations are from MRI center. For people using TIVA pumps, if there is anybody in this, in today's listeners who uses TIVA pumps, what I want to tell you is that there are no MRI compatible TIVA pumps, no MRI safe TIVA pumps available as I make this presentation. Yet there is not a single TIVA pump which is MRI safe. So then, what is the solution for using TIVA pumps? There is a solution. There is a solution. The solution is called a Faraday cage. So always, if you want to use the TIVA pump suppose you have remifentanil, you want to use remifentanil for your patients. Suppose you want to use Dexket or Dex alone, you can use it with a pump if the pump is in a Faraday cage. What is a Faraday cage? Faraday cages are specialized MRI compatible enclosures or housings which allow the use of MRI non-compatible TIVA pumps in MRI suite. Once the TIVA pump is placed in that cage, inside that enclosure, then it can be kept next to the MRI also. And the MRI magnetic field does not impact the performance of the TIVA pump. And the TIVA pump electromagnetic currents and induction motors does not impact the MRI image. The Faraday cages are designed to shield the pump and the batteries within them from the magnetic fields of the MRI and the MRI scanner from the electromagnetic interference coming out from the TIVA pump. Michael Faraday was a British physicist who is called the father of electricity. He is the person whose name has been given to these cages, which are called Faraday cages. These are examples. This is called a product by Fresenius Kabi. It's called Agilia. It has 2 TIVA pump, 3 TIVA pump, and 4 TIVA pump options. So this cage, it has a door. You shut the door and you can continue using the TIVA pumps in an MRI room. Sorry for the poor resolution, but this is another image wherein there are 4433 pumps put next to the. Can you see the MRI machine behind with the person wearing the blue scrubs? There is an MRI machine. The patient is about to enter the MRI bore, and this is a Faraday cage inside which a TIVA pump can be placed. There are MRI compatible laryngoscopes. This is all marketing, easy connection of blades and handle. It works with a xenon lamp. Includes one MRI compatible laryngoscope battery. The laryngoscope battery also has to be MRI compatible. And there is a certificate of up to 3 Tesla compatibility with MRI with this kind of a laryngoscope. Now, always remember, if the laryngoscope or any equipment is compatible with 3 Tesla, it can go with a 0.3 Tesla machine. If it is compatible with a 3 Tesla, it can be used with a 1.5 Tesla machine. If it is compatible with bigger magnet, it can work with a smaller magnet. But one which is compatible for a smaller magnet cannot be used with a bigger magnet MRI machine. Remember that. This is an Abbott manufactured pacemaker. I will request everybody to switch off their microphones because everybody speaks in that room also. It is heard here. Thank you. So this is an example of a wireless, leadless pacemaker, which is MRI safe, manufactured by Abbott. It is a pacemaker from Abbott, which goes and sits in the left ventricle. So there is no wire, no cable. So, in those ICU X-rays, you see those pacemaker wires, they don't have wires. They are wireless. They are leadless. This device is smaller than a vitamin tablet. There are multivitamin tablets, smaller than that also, and it goes and sits in the left ventricle. There are MRI wheelchairs. This kind of labeling behind the wheelchair is very essential, particularly multi-speciality and medical colleges. There are 50, 20, 10 wheelchairs here and there lying. You don't know which wheelchair to rush with. And if your patient is taken in an MRI, it has to be an MRI wheelchair. So it has to be written like this behind the wheelchair. Insist that if the chair is not written MRI wheelchair, it may not be MRI safe. There are wonderful MRI safe watches available. So if you are an anesthesiologist who frequents an MRI room, buy one of these watches. You can walk inside the MRI room with this watch and you can keep a track of your time also. Nowadays, there are balls, cricket balls and tennis balls and sports balls, which have a GPS tracker installed inside. Now, this is a Kookaburra ball. Kookaburra is a white ball which is used in cricket. Now, can you see the GPS tracker in the hands of that person? I'll show you another. That is called Kookaburra smart ball. These are called smart balls. Now, in today's world of smartphones, smart TVs and smart watches, there are smart balls. These balls are fitted with magnetic strips, iron oxide or GPS trackers impregnated within them. So why is it required? In tennis balls, even the lawn tennis, people who play tennis, those balls have magnetic strips inside. They have iron oxide powder impregnated in the rubber of the ball. Tennis balls. Why they do that? Because like in cricket, they use digital review system. In tennis, that magnetic powder or that iron oxide powder and the magnetic strip tells whether the ball has fallen outside that line, beyond that line or inside the line. So all these new technologies are coming, because of which these balls also contain ferromagnetic substances. Why I'm trying to tell you all this lesson learned is, it can be beyond the scope of one's imagination what can have ferromagnetic components. I request everybody to switch off your speaker phones, please, because if somebody speaks in your room, we can hear it here. If you are listening, please switch off your speaker phone. So, somebody with iPhone, can you please switch off your speaker, please? Yes, thank you. So lesson learned is, it can be beyond the scope of one's imagination what can have ferromagnetic components, and hence, unless proven to be MRI safe, we mustn't take anything for granted. In fact, an undertaking or a declaration from the attendants and the patient would be very prudent and legally safe. I will recommend that you take a consent or a declaration that I have been told about the problems of an MRI, and I hereby give an undertaking that I am not carrying any metallic object with me inside. Because once this happens, any missile effect or any dangerous projectile inside, because of they having not declared to you that they are carrying it, you will be absolved from the responsibility of, you should have a consent from the patient. A very interesting component is makeup and MRI. How many of the listeners here know that there are certain types of makeup which cannot go in an MRI room? I'll tell you, because young anesthesiologists, marriageable young girls who are about to get married, often they use certain types of makeups. I'm sure everybody must be surprised, but I'm going to throw a light, elaborate light on this area. This is called permanent makeup. Permanent makeup. It is called permanent makeup. It is not permanent. It's not for lifetime, but it is long-term makeup. Examples are dermapigmentation, micropigmentation, permanent cosmetics, semi-permanent makeup, and cosmetic tattooing. These are all dangerous in an MRI. All our cricketers, you see Virat, you see Surya Kumar Yadav, everybody is having big tattoos. Even the Western European players have big tattoos. Tattoos are dangerous in an MRI room. This is Deepika Padukone. I have deliberately taken this close-up picture. It is widely discussed. Her eyebrows are not real. They are artificial permanent makeup eyebrows. Now, these eyebrows, there is no hair. This eyebrow does not contain a single hair. It is all pigment. And how these eyebrows are created, and that is why they are very artistic, and the way the particular person wants, that kind of eyebrows are made. This is a pigmentation eyebrow, which is done like this. And it is done by 3 processes. It is called microblading, microgrilling, and microshading. These 3 mechanisms or 3 methods are used in which iron oxide particles are impregnated into the skin, the dermis of this brow area, and an eyebrow is created, a shape is created depending on the choice of the person who makes that. So it is very widely discussed. Deepika Padukone also has got those very shapely eyebrows because they are pigmentations. They are not hair at all. Even tattoos which men, not only females, even men have these big tattoos. And the most dangerous is this. Full body. Now all these dark color tattoos, darker the color, more dangerous. More larger the tattoo, more dangerous. Small tattoo, less dangerous. Less dark, less dangerous. All these colors contain iron. They contain ferrous particles. The dark component is because of ferrous particles. And these ferrous particles come under the influence of the strong magnetic fields of the magnet. And they get aligned with the magnetic field and they develop irritation. And there is skin irritation at each place. Patient starts feeling burning sensation in all of them. And okay, this is most important. I forgot to tell you about one more permanent makeup. There are magnetic eyelashes and magnetic eyeliners. I have deliberately shown you a picture. The eyelashes are artificial, eyeliner is artificial, and there is a magnetic component in that, which is very dangerous for an MRI. These magnetic eyelids and magnetic eyelashes. Now you can ask any person, model type patient or heroine type patient, you can always ask, very young, good looking patient, you can ask, are you wearing any permanent makeup? Are you wearing any artificial lashes or artificial eyelids? Because many people have this. So now this is going to be in vogue in the coming times. You will have to ask all these questions. This is an impact of what MRI does to a tattoo. Now these are blisters because of heat reaction, because of the iron oxide being influenced by the magnetic fields. So this is what the MRI does to the tattoo, and this is what the tattoo or the makeup does to an MRI. This is a normal image, and this is a makeup artifact look at the eyeballs. This is how the normal eyeballs look in an MRI, and this is how the eyeballs look in a patient with magnetic eyelashes and eyelids. So with magnetic lashes and eyeliner, the eyeballs also will not be seen properly. They will the signals will be lost in that area. So this is how the makeup also has an impact on the MRI images. Now, is the MRI magnet ever off? This is the question. Now, there are 3 types of magnets used in MRs. They are resistive electromagnets, permanent magnets, and supercon magnets. Actually, the resistive electromagnets can be switched off, but the permanent magnets and the supercon magnets are never switched off. Even resistive electromagnets, if switched off, the cost of switching them on is so much that nobody switches them off. So from the time of installation, for 4 years, 5 years, 6 years in a line, the magnets should be presumed to be on at all times. So when you are outside the MRI room, everybody has to know this, that once you go inside, you have to stand outside the 5 Gauss line. Because once you go inside the 5 Gauss line, you are subjected to the MRI magnetic field, whether the MRI investigation is going on or not going on. Whether there is a patient in the MRI machine or no patient in the MRI machine, the magnet is on all the times. All of you, please remember this. So if it's a resistive electromagnet, then there are some places where they switch it off in the night and they switch it off again in the morning. But they have to be very busy places where 80 patients are done. Only they can afford to switch off and switch on. Otherwise, none of the magnets are switched off. Almost always on. In other words, their magnetic field is active at all times. So I thought there was, so if the anesthesiologist says, I took the monitor or the laryngoscope inside because I just wanted to see if the patient has been taken. I thought there was no patient, so the magnet must be off and the magnetic field also must be off. If you say this, you will be presumed to be a joker because you are frequenting the MRI center and you don't know that the magnet has to be off, or you don't know when the magnet is on and off. So nobody will accept your ignorance if because of you some damages are caused. Anesthesiologists should display a high level of magnetic field literacy and understand MRI zones and Gauss lines. After this talk, I'm sure you will start inquiring into what are the Gauss lines? Are the Gauss lines drawn in your center where you go? So that even if the Gauss lines are not actually drawn, you would know the energy of the magnetic fields related to the distance from the magnet. You know how much safe distance to maintain. You should know which zone of an MRI department is safe and which zone is dangerous. So if you suppose now, let us presume your father is with you, your uncle is with you, and you have an MRI case, you carry your uncle to that place and you say, I will finish my case in half an hour and then we will go for some program. And that uncle has a pacemaker you don't know also. And you take him inside, you can imagine what will happen. So you have to keep your uncle in safe zone. You should know zone 1, zone 2 and zone 3. Keep your uncle, father, grandfather, auntie, whoever is accompanying you, relative in the safe zones, and you go into the magnetic areas, complete your case and come out. You ought to know if the MRI machine you work with is 0.3 Tesla, 1.5 Tesla or 3 Tesla. You cannot say, mere ko kya malum, I did not know, I came for the first time to do a case. No, you don't go to an unknown MRI center if you don't know anything about that center. Problems with pediatric cases. Biggest graveyard for anesthesiologists is pediatric case in MRI. You open Google, look for litigations in India against anesthesiologists. You will get a long line of litigations in pediatric cases against anesthesiologists in MRI. Because this is the biggest graveyard for anesthesiologists working in MR. Please be careful. In MRI, what are the problems with pediatric cases? Weighing scale will not be available to calculate dosages. You don't know, you cannot know the weight of the patient. So the weight which the patient's weight file as somebody else has written, you have to rely on it. So you have to make a weighing scale available. If you are a regular anesthesiologist, insist that there has to be a weighing scale there. Preferably you weigh yourself. Don't rely on the technician's weight or sister's weight which was taken in some other ward. Only adult pulse oximeter probe is available. If there is a pulse oximeter in the MRI center, pediatric probe is not available. Common problems which I am sure you all, if there is anybody doing MR cases, you also must have experienced this. Pediatric probe for the pulse oximeter is not available. No availability of pediatric IV cannula, but there are big 20 gauge and 22 gauge and all, but no smaller bore IV accesses, no pediatric masks, no pediatric ambu bag, no post-procedure recovery bed to observe the anesthetized child. This is very common. Again, if it's a medical college, if it's an institute, it's okay. But the standalone diagnostic center, there is no recovery room at all. So there is no bed, separate bed to keep the patient and observe the patient. So if you go to a new center, go ahead first visualize all these things because the child is likely to be under sedation for a long time after the MRI is over. So look for post-procedure recovery beds availability. And you must be standing next to the child and monitor everything. Now see, this kind of a cover is covering the patient's head. So visibility, and this travels inside the bore. So visibility is very poor. You have to be close to the patient. If you are sitting in the console, it is you to blame if the patient becomes bad. So you must be standing next to the child and monitor everything. Depth of breathing, lip color, wakefulness, like you do in an operating room. This is more dangerous than an operating room also. You have to be more cautious in the MRI room than what you are in the operating room. So please be standing next to the precious child that you are giving anesthesia. Now, this is another ventilator. It is called Hamilton ventilator. Please note down Hamilton. Very, very expensive. This costs 26 lakhs. But this is an MRI safe ventilator. It has all in newborn modes also. Neonatal mode, infant mode, child mode, everything. Hamilton ventilator. But institutes can afford, medical colleges can afford. So I'm just telling you, aisa hota hai, ye hai. So if you feel you can afford, your center can buy it. But otherwise, that 30,000 one which I showed you is best. Now, MRI. Now, what are the problems with pediatric cases? Why pediatric patients become bad in MRI? MRI safe gadgets are expensive, hence unavailable. MRI safe oxygen concentrators don't exist. So regular oxygen cylinders cannot be taken in an MRI room, and aluminum cylinders will not be provided. So they are out of bounds. They are very expensive. So nobody will give you aluminum cylinders. So how will you give oxygen to the patient? Either the oxygen has to come by central lines in the gantry room, in the MRI room, the scanning room. There have to be central lines, central gas lines. So they are outside the gas lines. So from there you can bring a tubing. Or jumbo cylinders have to be kept outside, and the tube should be brought long. Silicone tube should be brought inside and administered to the patient. Or they should provide you an aluminum oxygen cylinder and refill it. That is enough. 155,000 cylinder can suffice for years. You can just keep refilling it. Ventilator and workstations are presumed to be an overkill in gadgetry. Means If you ask for a ventilator, they will say, what doctor you are? Who will give you a ventilator in an MRI? One case in 1 week or 2 cases a month. Who will give you ventilator? This is what the radiologist will say. But ventilator and workstations, that is why they are never provided. Institutes have everything. Medical colleges will have everything. But yet the whole country does not have workstations and ventilators in MRI rooms. We need to have these kind of discussions so that people become aware and anesthesiologists start insisting, if you want me to anesthetize a baby, there has to be a workstation with pediatric settings. Otherwise, I don't come. There is no formal global registry for MRI death statistics. There is no formal registry. So how many ever patients have died in an MRI room? There is no record. No perfect statistics is available. How many have died because of poor monitoring? How many have died because of hypoxia? How many have died because of anesthesia complications? How many have died because of MRI complications? How many have died because of missile effect and dangerous projectiles? No data available. These factors make our pediatric cases the most vulnerable to fatal mishaps. A very, very heart-wrenching case. I must tell everybody, you must all know this case. This is a patient, this child, Buddhi Ratnayake, 5-year-old female, a Lankan child from Sri Lanka. She was put into the machine to investigate her for epilepsy. 5-year-old child, an anesthesiologist was present. The child's mother were present in the MRI rooms. 2 people were there in the MRI gantry room, anesthesiologist and the child's mother. A loud explosion was heard after the baby was put into the gantry and the scan was about to start. A loud explosion was heard and the baby started turning blue. The anesthesiologist shouted. This is recorded in the legal papers. The anesthesiologist, she was a lady, poor lady. She did not know. This is 2013 case. They're quite old. The anesthesiologist shouted, is nobody going to come and help me? The oxygen pipes have burst. This is what she said. That loud sound which she heard actually was not oxygen pipes, but this is what she said at that moment. Later on, it was discovered that it was not the oxygen pipes. But suddenly it became cold in that room. And because it became cold, she thought that it is the liquid oxygen or something like that. She said, is nobody going to come and help me? The oxygen pipes have burst. The child's mother said that the anesthesia doctor shouted like this in the Sinhalese language. The blue baby was shifted to an ICU, but she could not be revived. The autopsy revealed hypoxia as a cause of death. Now, what actually had happened is called quenching of the MRI magnet. What is quenching? Sudden quenching had happened. It's a technical error in the machine. When the liquid helium, in certain MRI machines where there is a superconducting magnet, the magnet is kept in a jacket of helium. And that that is liquid helium. Liquid helium is very, very cold, minus 30 degrees or something, very cold. So the liquid helium surrounding the supermagnet, if that jacket suddenly bursts, it causes a big bang sound. If that leaks, there is a big bang sound. Doom sound comes in the MRI room. And the helium liquid instantly converts into helium gas, which leaks into the ambient room air. It mixes with the ambient room air, very instantaneous. And believe me, the ambient oxygen levels dramatically drop because the liquid helium to gas conversion is a 1:700 expansion of helium. 1 ml liquid helium becomes 700 ml helium gas. So whatever helium jacket is surrounding the magnet into 700 is the concentration of helium in that room suddenly. Suddenly the oxygen in the ambient air drops. At such times, if your child is already on supplemented oxygen, that child will not fall prey to the helium. You will be able to lift up the child and leave the room before the helium takes over. This poor child became hypoxic because she must not be on oxygen. This liquid helium converting into gaseous helium is a cryogenic reaction. So the ambient temperature also plummets dramatically. Sab thanda ho jata hai. Everything becomes cold. Why? Because the liquid helium converting into gas is a cryogenic, a cold generating reaction. Since sudden quenching and missile effect both cause a loud bang noise, the reporting of life-threatening accidents is inaccurate in details. So whenever there is a record of a bang sound, there is no record whether that big bang sound in the MRI came because of a dangerous projectile, because of the missile effect, or it is because of sudden magnet quenching. Nobody records. There is no registry in the world, so nobody knows whether that death was because of quenching or because of missile effect. Nobody knows. So I am towards the end of my talk. I am here to give you the take-home message. a single loud take-home message I want to give everybody who heard me today is most essential prerequisite in an MRI room is you must know how to terminate a scan and how to get the patient out of the bore in an emergency. Before starting the patient study, call the technician, go in the MRI room and ask them, how do I say emergency stop? How do I press, which button should I press to get the patient out of the bore? If the patient is hypoxic, if the patient is apneic, I want to start breaths, I want to umbu the patient, how do I pull the patient out? Learn it from the technician and then only start the case. You should have some pre-decided sign language to communicate with people across the lead glass, not lead glass, across the glass in the console room. Lead glass is in CT scan, MRI, there is no lead glass, but there is a glass. So you need to have some sign language that you tell them that there is a dire emergency. Stop everything, stop everything. You cannot talk. Whatever you talk is not heard in that control room. So in order to declare an emergency, there has to be a sign language pre-decided between the anesthesiologist and the radiologist who never come in the gantry room. Only you have to stand there. So be ready to pull the patient out, how to get the patient out, how to communicate with the radiologist. Prepare that. This is first take-home machine. These are the buttons on the MRI machine. Learn those buttons. Which button, when pressed, the patient will come out fastest. Usko seekh lo. Before you start doing before you administer any anesthesia, any sedation to the patient, you must be well versed with that MRI machine. And all these buttons, if you don't know, you will struggle with that. Technician will take time to understand that something has gone wrong. You will not be able to stop the diagnostic process. You will not be able to stop the MRI machine. You will not be able to remove the patient, and precious moments will be lost, and the patient also can be lost. So in these MRI suits, we are the only ones to understand that the patient is deteriorating and needs urgent attention, even at the cost of interrupting the scan. Be bold and stop the study, get the patient out, supplement oxygen, tell them, I'm sorry, patient became serious, now the patient is okay, please start the scan again. Let them curse you, nothing happens. The patient should not succumb to a complication or hypoxia or apnea, and you are the custodian of the patient. Nothing exceeds the importance of our patient's life, and nobody but we are the custodians of his or her well-being. This is the take-home message I wanted to give you. Thank you. Thank you very much for this opportunity. And I hope I have elaborated all the aspects of anesthesia in an MRI room. I'll stop sharing my screen now. I have stopped sharing. I have finished my talk. Yes, I will answer. Can you hear me? Can I be heard?
Sir.
Yeah. So somebody has asked a question, can inhalational agents be provided? Certainly it can be provided. If the workstation you are using is MRI safe and the vaporizer you are using is MRI safe. Inhalational agents have no problem by themselves because of the magnetic field. The machines which dispense the inhalational agent, that is the vaporizer, has to be MRI safe. And the vaporizers which we use in our operation theaters are not MRI safe. So you use a workstation or a MRI or a vaporizer, you can jolly well administer inhalational agents. Okay, any more questions? I'm just having a look. No, I don't have any more questions. Are there questions going to be put in the chat box, or you are going to be going to ask me directly? Praveen, moderator sir, can you please ask the organizers, are there any questions? I don't know if the questions are going to come in the chat box. Have they received any questions?
Okay.
Hello.
Yes.
Thank you, sir, for nice presentation.
Thank you.
Sir, any questions? Ramakrishna Reddy, sir, and Prasad Rao, sir, Mohan Reddy, sir. So only one question came, sir. That is,
Can we give inhalation?
any inhalation agents can be provided?
I have answered that question. Has everybody heard me, or should I repeat my answer? Inhalational agents can be administered if the vaporizer you are using is MRI safe. If the vaporizer and the workstation you are using are MRI safe, again I repeat, if the vaporizer and the workstation are MRI safe, inhalation agents can be administered. If not, please don't take those equipment also into the MRI room. So inhalation agents can be administered with MRI safe equipment.
Sir, good evening, sir.
Please
if
ask.
I want to do MRI for a pediatric patient.
Okay.
If I want to do MRI for a pediatric patient.
Yes, sir. Can't hear your question.
Is it better to intubation or sedation?
No, sedation. See, I told you most of the cases are only immobilization is required. So if that is required, only immobilization is required, patient has no saturation problems, no chest, no lung mass, no mediastinal mass, nothing, then you can give sedation and supplement oxygen, but no case without oxygen in MRI. This is my very, very strong recommendation. No need to intubate if the patient doesn't need intubation. If only intubated patients will have to be kept with the tube inside. That is why you have to know how to operate how to conduct the anesthesia in an intubated patient. But only for the MRI sake, you don't need to intubate. If there is no suspended respiration demanded by the investigation, if there is a mediastinal study, if there is a chest study, then you need to suspend the respiration till the MRI is complete. In that case, you will have to intubate. But if it's a head MRI, if it's a neck MRI, a body MRI, limb MRI, joint MRI, then you need not suspend the respiration. Respiration can go on. Only immobilize the patient. So if immobilization is the target, sedation is enough.
Thank you so much for the...
Sir, excuse me, sir.
Yes, sir.
I am Dr. Prasad Rao, sir, from Jim, sir. Actually, I recollect one incident that happened in our gym, sir. This is in Vizag.
Okay,
a patient, actually, this missile effect, we had that experience.
Oh.
One oxygen cylinder, just it had missile effect and directly attached to, like a missile, to the rim of the what you call patient entry.
Yes.
So luckily, nobody was injured. It just crossed past our postgraduate. He just luckily survived. But thing is, how it happened, if you recollect, that ward boy, ICU, that patient came from ICU, that boy, all of a sudden, without informing, he just brought the patient in with a couch and oxygen cylinder. So by the time he entering the room and the door, that cylinder, there was a big bang and the cylinder was there, not here. So luckily we could avoid all that. But what I want to tell all the people is that these fourth class people like boys and ayas, whoever bring the patient with couch, they need to be actually addressed very well regarding these safety issues. Otherwise, they are the persons who don't know about this anything at all. Though we know, they don't know. So from behind, he brought the couch. So nobody knows. By the time there was a big bang, we could notice that patient is behind and he brought it inside. So a lot of education to that boys, ward boys and OT assistants. It is mandatory, I think, in any medical college or the hospital.
Correct, sir. Correct. Very true. And also that makeup and MRI, which I told you, all high-end, high, what do you say, rich areas like Banjara Hills in Hyderabad, Malabar Hills in Mumbai, or Lutyens area in Delhi, all premium localities, you have to ask for permanent makeup, because the higher class, higher society, women with permanent makeup. So don't underestimate that. They will get burning sensation, they will sue you. So you should ask, are you wearing any permanent makeup? Don't underestimate. They can all develop irritation and burning and dermatitis.
So they should be warned of the consequences.
Yes,
Before.
yes.
Yes, sir.
Thank you so much, sir, Dr. Nilesh, sir. And thank you, moderators, chairing the session, Dr. Ramakrishna Reddy, sir, and M. Prasad Rao, sir, and Madan Mohan Reddy, sir. Now we are going to second session, interpretation of chest X-ray. I would like to invite Dr. Padmavati Vigrahala, ma'am, Professor Gayatri Medical College. Welcome, ma'am. I would like to invite Dr. Varprasad Garu and Professor and Department of Radiology, GMC, Rajamahendravaram. Welcome, sir. I would like to invite Dr. J.V. Praveen, Associate Professor, Department of Pulmonology. Welcome, sir.
Thank you, ma'am.
Please start the session, sir.
Good evening, respected faculty, and today I am going to present on
Dr. Ashok,
yes,
postgraduate
ma'am.
Gayatri Medical College. He is
Yes,
presenting the interpretation of chest X-ray. Thank you. Ashok, any problem?
పొద్దున మట్టి బాగా పెట్టలేదు ఎప్పుడు అంతే లాస్ట్ టైం అట్టాగే అయిపోయింది అన్నమాట.
ఇప్పుడు ఓకేనమ్మా? Dr. Ashok. Any? Please see now. Praveen sir, ఒకసారి
Hello, ma'am. Hello, sir. Good evening, sir. Am I audible, sir?
Yes, yes, you are.
Yes, sir. Thank you, sir. Till now, my screen, my mic was unmuted by presenter, sir. So now I'm presenting, sir. Yes, sir. అంటే నేను అన్మ్యూట్ చేశాను మ్యామ్. ఇక్కడ పర్మిషన్ ఇవ్వలేదు.
Okay, Ashok, go ahead with the presentation. Ashok, unmute yourself.
Hello, am I audible, sir?
Audible, sir.
Ashok audible.
You are audible.
Yes, ma'am. Is my screen available? Is my screen shared?
Screen visible.
Screen visible, but enlarge చేయండి. Single slide show పెట్టండి.
Yes, ma'am. Thank you, ma'am. Good evening, ma'am, and good evening, respected faculty. And my name is Dr. Ashok, and I'm postgraduate in Gayatri Vidya Parishad. And I thank the opportunity to thank for these organizers for giving this opportunity, and I thank my moderators. And coming to the importance of chest X-ray, and it is one of the most common frequently used investigation in the perioperative medicine and critical care. As anesthesiologists and intensivists, we has a good use of it as it serves as a rapid bedside tool that directly influences the airway management. And it also useful for guiding the ventilation strategies and hemodynamic decisions and overall patient safety. And coming to the role of chest X-ray in perioperative medicine, it is useful in the risk stratification and optimization of the patient to take up for the surgery. And in ICUs, we identify the cause of sudden hypoxia or hemodynamic instability, and we also monitor the disease progression, complications, and if there are any devices introduced, we also can use this chest X-ray for device positions. And
Dr. Ashok,
sir,
your presentation is not moving. Your slides are not moving. Are you expecting to change the images on the visible on the screen? Then we are not your same.
Is it now, sir?
Yes. Now it is okay.
Yes, sir. I have enlarged, sir, but it was not changed. Now I am going to present it like this.
It's not unless slide share mode, you can press it, no? Down, right side.
Slide share పెట్టాను మ్యామ్, అవ్వట్లేదు ఇప్పుడు మ్యామ్.
I think not coming.
Not yet full screen.
Okay, and okay, you can start.
Yes, ma'am. And it is and we have the views of chest X-ray like PA view, which is a gold standard view, and it is best for anatomical accuracy. And we have AP view, which is we commonly use in ICUs and ERs where patients cannot be mobilized, and where it has a enlarged cardiac size. And we have supine views like in critically ill patients where we take the chest X-rays of ICU patients. And in supine view, where we rarely frequently miss the pneumothorax if present. And in lateral view, it helps to localize the lesions and but rarely feasible in the ICU patients. And these were the images that shows the source of chest X-ray and where we get the X-ray cassette, so that we can get the view. That is, if the cassette is presenting position of the patient is facing away from the source and cassette is on the side of the opposite side of the patient, we get the AP view. And if the patient is facing towards the X-ray source, and where the cassette is on the back side, and we get the PA view. And the third one is the lateral view, where the patient can be patient is kept to be stand on the lateral side, that is from the either right side or left side, so that we can get the lateral views depending on the requirement. And to see the chest X-ray, we need to identify and verify the chest X-ray of a patient. Initially, we should always check the patient identification, that is name, age, and sex, and hospital administration, and hospital ID and registration number if available. And we also need to check the date, time, and verification, so that if the X-ray is a recently available one or a previously taken one, or we can also assess the date and time to assess the progression of the disease if needed. And side and orientation marker are essentially kept so that we can know the whether it is an right sided marker present or left sided marker present, and it correlates with the normal anatomical structures. And the projection and position is also mentioned on the chest X-ray, that is either AP view, PA view, or lateral view. And in some institute they mention whether it is an erect spine or semi-erect position, and it helps to differentiate the localizing the pathology. And coming to the technical adequacy, there is a ripe criteria to follow while taking an X-ray. That is, R stands for rotation, I stands for inspiration, P stands for projection, and E stands for exposure. And in rotation, the medial ends of the clavicles must be equidistant from the spinous processes, and we measure the distance between the collarbone and we measure the distance between the collarbones and the central spine, and the measure between the spine and we should measure the distance between the spine and both outer chest walls. And we should check the upper spine and upper spine whether it is straight or vertical. And we also see for the airway that it is whether rotated or any deviation present. And we also need to check for the symmetry, so that it is a straight X-ray or any rotation is present, as the rotation is needed, because even in a AP X-ray, if the if the rotation is towards the left side, there will be enlarged cardiac shadow, and it may leads to the misinterpretation of the misinterpretation as a cardiomyopathy. Or if taken, if it is rotated to the left side, it may heart shadow may appear as a small one. And I stands for inspiration, and as a good inspiratory film provides adequate details, and also there should be at least 5 to 6, more than 6 anterior ribs and more than 10 posterior ribs should be present on the chest X-ray to identify it as a good inspiratory film. And the poor expiratory films may mimic the pathology, like the lung bases may appear whiter, and heart shadow may appear larger, leading to the misdiagnosis as a cardiomyopathy. And coming to the projection, projection also provides projection also gives whether it is an AP or a PA view that affects the cardiac interpretation. And coming to the exposure, the exposure should be kept at adequate KPS, that vertebrae just should be visible through the cardiac shadow. And this poor technique of not following the right criteria may mimic or mask the pathology present in the that can be diagnosed through a chest X-ray. And these were the common errors due to poor technique. As we can see that in this image, there will in an if taken in a AP view, we may falsely interpret the chest X-ray having a patient with a large heart, and where the poor inspiration can also mimic the basal consolidations or effusions, and the rotation also mimics the mediastinal shifts towards the side, rotated side. And coming to the systemic approach, we follow a ABCD method, as this fixed sequence ensures there will be no structure missed in the reading the chest X-ray, especially during the emergencies, where A stands for airway, and the airway is the in airway assessment we should always check for the trachea placement, whether it is centrally placed or deviated to either one of the side, or and the carina must be identifiable, and which should be located at a T4 level. And if there are any endotracheal tubes or tracheostomy, the tube position can be assessed, and any airway abnormalities or tube malpositions can cause the hypoxia in the patients. And coming to the B, which is a breathing, that is a lung fields and the pleural assessment. We compare both left and right lung fields for symmetry, and we can divide the lung zones into upper, middle, and lower zones. And we should always compare bilateral sides so that opacity or lucency is missed or overread. And we should always compare both sides systematically rather than interpreting the isolated fields. And this is the image representing the all the structures present in the chest X-ray. That is clavicle, trachea, carina at level T4, and ribs that were anterior, posterior, and there is a gastric shadow below the diaphragm, and right prostophrenic angle and left prostophrenic angle, and the gastric cardiac shadow can be seen, and the spinous process beyond the heart shadow can also be seen in this X-ray. And coming to the cardiac assessment, the heart borders were formed on the right side by right atrium and superior vena cava, and on the left side it is mainly formed by the left ventricle, and the upper left border is continuation of atrial appendage and pulmonary artery, and the lower border is formed by the left ventricular apex. As the aortic knuckle, which is a smooth, well-defined contour just located above the left hilum, and it is continuous with the descending aorta. And a prominent aortic knuckle can be seen in patients with the hypertension, atherosclerosis, aneurysm, or some age-related unfolding of the aorta. And loss of definition may leading to we can suspect that if there is any adjacent consolidation, pleural effusion, or any mediastinal mass that obscure the border. And there is a shill out sign, that is the normal obscuring the normal differentiation of the heart borders by the pathology, leading to the obscuring the borders of the heart, that is due to either by consolidation or effusion. And finally, the cardiothoracic ratio, that is of if the heart size should be less than 50% of the entire thoracic ratio, that should be always assessed in a PA view, and it is always unreliable in AP view, as the chest as the heart stays more closer to the X-ray beam, it appears always enlarged in a AP film. And if there is any more than 50% of CT cardiothoracic ratio is there, we can always suspect for a cardiomegaly. And coming to the diaphragm assessment, the right diaphragm normally is of 1 to 2 centimeters higher than the left side due to presence of liver below it, and the left diaphragm has a gastric bubble beneath it. And the costophrenik angles were sharp and acute. If there is any gas shadow present below the diaphragm, right diaphragm, we can always suspect the abdominal perforation like things. And coming to the last one, everything else that includes bones, soft tissues, and devices. In bones, we always assess the ribs, clavicles, scapula, and vertebrae. The findings can be if there is a rib fracture, there will be a sharp discontinuity, and if it is a healed one, we can also see callus formation. If there are any vertebral anomalies like scoliosis and compression fractures can also be seen. And clavicle fractures, there will be displacement if visible displacement if it is a displaced fracture on the chest X-ray. And coming to the soft tissues, the findings were in this we can see emphysema, that is streaky lucencies in the chest wall or neck. This is due to subcutaneous masses or swelling present in the tissues, and brush shadows can also be seen in these patients. And coming to the clinical impact, the emphysema is often indicates the pneumothorax or a tube malposition that must be recognized quickly and treated so that collapse can. Coming to the devices, the common devices visible on the chest X-ray were we order the chest X-rays for after device insertions like endotracheal tubes or central CVP lines or chemotherapy ports or any chest drains. And the endotracheal tube should be present at least 4 to 6 centimeters above the carina, and central venous catheter tip should be present at the junction of superior vena cava and right atrium, which is approximately at the T6 level. And if there is an intercostal drain, the side holes of the intercostal drain should be within the pleural cavity. And if nasogastric tube is kept, the tip should be below the diaphragm and in the stomach. And the complications of these were malposition of these devices leading to the hypoxia or ineffective drainage, or may have a risk of perforation. And pneumothorax after central line insertion can cause decreased lung hypoxia in these patients. And coming to the preoperative chest X-ray indications, we routinely should not order the chest X-ray for ASA grade 1 and grade 2 patients. And we can order the chest X-ray for patients with the cardiopulmonary diseases in elderly patients, and the patients with who is undergoing for a major thoracic or upper abdominal surgeries. And also the patients with a history of past tuberculosis and smoking or a malignancy. And coming to the, we commonly come across these chest X-rays like a consolidations. Consolidations were alveolar filling with the pus, fluid or blood or cells with non-uniform borders. And the most common causes were pneumonia, aspiration, and pulmonary hemorrhages. And as these appears as a homogeneous opacity in the affected lung zone. And the consolidation represents the loss of air content in the alveoli with the fluid filled. And these air bronchograms can also be seen, and the air as a hyperlucency present in the consolidation. And there will be no volume loss in the consolidated consolidations. And sometimes the silhouette sign can also be seen in these patients as they completely disrupt the borders with the chest heart sign or any lung zones present in there. And these air bronchograms were the hallmark feature of the consolidations. And the consolidation reduces the oxygen reserve, which leads to the risk of hypoxia during the induction of the patient. And aspiration pneumonia is an active as it is an infective etiology leading to the we should always take control measures to control the infection. And coming to the post-op consolidation, these are common cause of fever and desaturations, and we should always order a chest X-ray if a patient is going desaturating and having a continuous fever in the post-op. And we must differentiate these from the collapse or effusion to guide the management, whether to continue the patient on antibiotics, or we should go for a chest tube drainage. And if there is a collapse, should we go for recruitment maneuvers. And coming to the collapse, there is an increased, it is seen as an increased opacity on the affected lobe or segment with uniform borders. there will be volume loss due to, and also it can be seen on the chest X-ray as there will be a tracheal deviation towards the lesion and a midline shift towards the side of the collapse. And there will be elevated hemidiaphragm on the side of the lesion. And also due to this pull, the crowding of the ribs and vessels can also be seen. And it as there is a pull towards the collapse, there will be displacement of the fissures and compensatory hyperinflation on the opposite side, opposite lung. Coming to the abscess, these can be identified as a local pus-filled cavities within the lung parenchyma, and usually these are secondary to the aspiration pneumonia or bacterial infection or septic emboli, and they appear as a cavity with the surrounding consolidations, and they were like a thick walled. They present as a thick walled cavity with irregular margins, and there will be air fluid level, which is a classic sign seen on the abscess chest X-rays. And these were often located in the dependent lung zones, that is posterior segment of the upper zone or the superior segments of the lower zones. They present a aspiration risk due to copious purulous secretions, and patient may land in sepsis due to may land in sepsis, and we should always take precautions for airway management, and there will be reduced reservoir, so we should always anticipate the risk of hypoxia. And coming to the patient with the patient with the history of smoking, we may get the COPD findings on the chest X-ray. That is hyperinflated lungs, leading to that lungs appear larger and darker than the normal regular X-rays, regular people, and they may have a flattened diaphragms due to reduced dome that is produced due to the air trapping, and there will be increased intercostal spaces as and there will be retrosternal enlargement if we go for if we take a lateral view. And due to these enlarged lungs, the heart appears as a floating within the cavity, and this can that within the cavity due to small and elongated due to the hyperinflation of the lungs. And these findings indicates there will be air trapping and increased risk of barotrauma and dynamic hyperinflation, and there will be difficult ventilation during the anesthesia procedure. And coming to the restrictive lung diseases, restrictive lung diseases were a group of diseases that included in these ILDs, that is idiopathic pulmonary disease, pulmonary fibrosis, sarcoidosis, connective tissue diseases that are all related to these, and these were these were observed as a fibrosis-like structures on the chest X-ray, where there will be a reticular pattern with fine lace-like lines across the lung fields, and some appear as a reticuloordinary opacities with the combination of lines and small nodules, and there will be a honeycombing appearance with coarse cystic changes, and usually in the lower zones. And these restrictive lung diseases patients will have a reduced lung volumes with reduced lung volumes, and this fibrosis pulls the diaphragm towards them, leading to the elevated diaphragm, and lungs may also appear smaller. These restrictive pathology provides poor compliance and rapid desaturation during the apnea, and these patients will have a reduced oxygen reserve. So we should always pre-oxygenate the patient, adequately pre-oxygenate the patient before going for going for
తెప్పించాను రాత్రి తీసుకెళ్ళిపోయింటే బాగుండేదాన్ని కదమ్మా.
honeycombing
ఉండి కూడా నేను తీసుకెళ్ళలేదమ్మా.
honeycombing and fibrosis changes for irreversible changes.
బాగలేకపోతే కూడా తీసుకెళ్ళలేదు.
Difficult intubation. And for all these reasons, we should always optimize the oxygenation and also avoid the high pressures so that trauma causing to the lungs. And coming to the tuberculosis, where active tuberculosis patients will have predominant lesions in the upper zones of the lungs, which are apical and posterior segments, and there will be patchy or nodular consolidations. and the cavitation will be thick-walled. Often multiple cavitations often multiple cavitations can be seen, and there will be hilar or mediastinal lymphadenopathy in the primary pulmonary tuberculosis patients. And coming to the post TB or healed TB patients, there will be fibrosis that left behind and scarring that left behind after healing, leading to the volume loss and tracheal deviation. There will be calcified granulomas that are called Gons focus present on the uh, uh, images, and there will be calcified hilar lymph nodes called Ranke's complex can also be identified in these patients, and there will be some patients may also have pleural thickening. And coming to the cavities are gas-filled spaces within the lung parenchyma within a wall. They are formed due by the necrosis, infection, or a malignancy. These were seen in severely affected tuberculosis patients and fungal infections or cavitating carcinomas. And there will be hyperlucency within the area of the consolidation of the mass with a thick wall, usually more than 2 millimeter thickness, and there will be air fluid level if they are infected. And the margin within the abscess is irregular. Inner margin will be irregular in the abscess or in malignancy, and the surrounding the cavities there will be always accompanied with the consolidation, fibrosis, or nodules. Now, coming to the effusion is a homogeneous opacity that appears always on the dependent or lower lung zones, and there will be meniscus sign that obscures the sharp angle of the costophrenic angle, leading to the blunting. And there will be mediastinal shift that away from the pleural effusion that pushes if there is a margin pleural effusion present. And layering of the fluid can also be found on the lateral decubitus view that confirms the presence of free fluid. These were the key differentiations between the opacities and cavities. The first table differentiates between the consolidation, collapse, and effusion. The key feature in the consolidation is air bronchogram, and it also has a no volume loss, and there might be chill out sign present due to obscuring the borders. And collapse has a opacity and tracheal shift, and there will be a volume loss, and as the collapse leads to decreased pressure, there will be mediastinal pull towards the collapse. And in effusion there will be meniscus sign and reduced lung volume due to push from the fluid, and these also pushes the mediastinum away from the lesion. And coming to the cavities which formed by tuberculosis cavity, abscess, and bulla, there will be in TB there will be thick and regular cavities with air fluid level if present. If there is an infection present, there will be an air fluid, and always fibrosis or calcified nodes also can be seen. In abscess, they are thick and irregular, and the air fluid level is always present, and consolidation. And coming to the bulla, these were of a thin walled, and there will not be any air fluid level, and they always have a hyperinflated than the rest of the lung fields. Now, coming to the plan of anesthesia, if there is an abnormal chest X-ray finding, we should always consider for oxygen reserve, ventilation strategy, and risk of complications like barotrauma, aspiration, and infection spread. We should always have different approaches for any elective or emergency surgeries. And coming to the elective surgeries, the planning should be we always go for a pre-optimization, that is to treat the patient for active infection. If there is any pleural effusion, we should drain with ICD. And if the patient is with COPD or interstitial lung disease, we should send the patient for pulmonary rehabilitation like incentive spirometry like. And for a tuberculosis patient, we should always take the infection control precautions. And the choice of anesthesia will be mostly we go for a regional anesthesia if feasible in these patients. If GA is required, we should carefully give low tidal volumes, prolonged expiration time, and lung protective ventilation is to be planned. And for the risk stratification, if the surgery is not immediately necessary, we can delay the surgery to resolve the acute pathology in the patient. When coming to the emergency surgeries, there will not be there will not be time for a full optimization of the patient. So immediately we should secure while securing airway, we should always anticipate secretions or collapse or effusion in these patients, and we should always optimize oxygenation. That is, pre-oxygenation can be done with masks or any HFNC available, and we should always adjust ventilation to a low tidal volume and careful PEEP, so that we should not cause any barotrauma in these patients. And for intraoperative vigilance, we should always watch for desaturation and raised airway pressures, and manage secretions with frequent suctioning, or if any abscess is suctioning in tuberculosis and in abscess cases. And for post-operative care, we should always monitor these patients in ICU, and early physiotherapy and NIV or ventilatory support till the patient is necessarily recovered. And coming to the ICU chest X-ray indications, the indications were after intubation or extubation of the patient, after any central venous catheterization or any chest tube insertion, and if the patient is going into sudden respiratory distress or any hemodynamic deterioration, and the chest X-ray should be used to answer the specific clinical scenarios in the ICU, so that we can adjust the further treatment management. And in for after endotracheal intubation, the ideal position is to be around 5 to 6 centimeters above the carina level in the neutral head position. If the low position is present, the endobronchial intubation may occur. Usually that goes into the right endobronchus, which is straight with the trachea. And if the position is too high, there will be accidental extubations can also occur in these patients. Coming to the pneumothorax and chest X-ray, the visible pleural line will be absent. Visible pleural line with the absent lung markings beyond the wall, and the increased lucency of the affected hemithorax can also be seen, and there will be deep sulcus sign present in the supine patients, where due to increased air trapping that pushes the diaphragm further down. Coming to the common pitfalls in the chest X-ray interpretation, we usually overdiagnose the cardiomegaly in the APU, and there will be missing pneumothorax in the supine films of the ICU. And this misinterpretation can also happen due to rotation or poor inspiration. And the most interpretation errors occurs due to failure to follow a systemic approach. And I have also added some case scenarios to give some examples, like a 68-year-old male patient with who is a chronic smoker who has bought 40 pack years. He is posted for a elective open hernia procedure, and he complains of exertional dyspnea and chronic cough. And on seeing the vitals, there is a 94% of room air saturation, and air entry is reduced bilaterally. And as this patient is after taking the chest X-ray of this patient, we can see the following findings. There will be hyperinflated lung fields with increased translucency, and there is a flattened hemidiaphragm due to air trapping inside, and increased intercostal spaces and the horizontal ribs, and there is a narrow and vertically oriented cardiac shadow that can be termed as a tubular heart, and increased retrosternal airspace on the lateral views. And the case scenario 2 is a 65-year-old smoker who undergoes an emergency laparotomy. On post-op day 1, he has a low-grade fever and mild hypoxia. And he has a classic sign on the left side of the chest X-ray, that is above the diaphragm. There will be a plate-like opacity that is linear and horizontal at the lung bases, and there is a elevation of the diaphragm on that affected side, which is pulled due to the lung volume loss, and there is a crowding of the ribs present on the side of the affected mass, which is a cause of atelectasis. Atelectasis of lung, and we can apply minimal PEEP to the patient so that usually resolves within 24 to 48 hours after applying the NIV with PEEP. And coming to the case scenario 3, a patient with a severe abdominal sepsis is intubated, and over 24 hours their oxygen requirement increases, and excuse me, ma'am. Their oxygen requirement increases to 60 to 100%, and after taking ABG, there is a PaO2 by FiO2 ratio that drops to less than 120. And we have a chest X-ray findings with this. We have white. This can be termed as a whiteout lung in sepsis or ARDS patients, which have a bilateral diffuse infiltrates with the ground glass opacities, alveolar opacities, and he has a normal heart size, unlike the heart failure patients where the cardiothoracic ratio will be more than 50, and the air bronchogums can also be visible in these patients with opacified lung, and there is no pleural effusions that typically lacks the effusion in the cardiac failures. And the fourth case scenario is there is a 72-year-old male patient that develops restlessness and desaturation 2 hours after the TURP procedure, and his BP is elevated, and crepitations were present bilaterally, and we suspected TURP syndrome, and we ordered the chest X-ray, leading to the following findings. It is a case of, it is diagnosed as a case of flash pulmonary edema due to increased fluid absorption into the body. There is a classic bat wing pattern with a rapid onset of perihilar opacities despite the normal heart size, and the upper lobe, the blood flow is redistributed to the upper lobes, leading to the cephalization of the X-ray, and it rapidly resolves after applying PEEP for 28 to 48 hours with proper diuresis treatment management. And there is a case, this is another case scenario with a patient with a permanent pacemaker that is admitted to the ICU, and we have to check the chest X-ray. We take the chest X-ray to check the integrity of the pacemaker. That is for leads to be coiled or fractures, if any fractures present on the insulation wire, and the tip positions, that is whether the atrial lead present in the atrial appendage and ventricular lead should be present at the right ventricular apex. And the complications were to rule out while lead insertion were pneumothorax. And the left side one shows the normal chest X-ray with normal post-procedure chest X-ray with atrial lead present in the atrial appendage and ventricular lead present in the ventricular appendage. And the right side image shows marked broken fractured limb of the pacemaker appendages. And the case scenario 6 is a 2-year-old is brought to ER after a sudden coughing while eating peanuts. On examination, there is a unilateral decreased breath sounds and localized wheezing on the right side. And while taking X-ray, The left side image shows the inspiratory film that has a normal looks like a normal X-ray, but when taken on the expiration, the peanut may forms like a valve-like structure that allows the air into the lungs, but doesn't allow air to expire from the lungs, leading to the pushing of the mediastinum towards the left side. And coming to the case scenario 7, there is a newborn with presents with the immediate respiratory distress with the sunken abdomen, and the heart sounds were heard on the right side when auscultated. And the pathognomonic finding is like the bowel loops present in the chest X-ray were multiple air-filled cystic structures in the left hemithorax, and mediastinal shift. That is, the mediastinal shift is also present due to the bowel loop pushes the heart towards the right side, and the absence of lung markings on the affected side due to it is either due to hypoplastic or due to hypoplasia or due to compression. And the abdominal gas pattern is not noticeable as there is no gas shadow present, and it is a classic case of congenital hemidiaphragmatic hernia. And the take-home messages were we should always assess the technical adequacy of RIPE before interpreting any chest X-ray, and we should follow fixed ABCD pattern for a sequence to not to miss any finding. And we should always radiologically correlate with the clinically correlate with the radiological findings. And the chest X-ray is a critical tool, but also critical patient safety tool in anesthesia, and it has a consistent application of these principles improves the outcome. Thank you. Hello, sir.
Thank you, Dr. Ashok, for nice presentation. Any questions from audience? Moderators?
Hello.
Ma'am. Good evening, ma'am.
How will you diagnose a pneumonectomy findings on chest X-ray? Like, what findings you will see in pneumonectomy chest X-ray?
Pneumonectomy, ma'am.
Post-pneumonectomy.
Post-pneumonectomy, ma'am. There will be reduced reduced space on the side that present on the
There will be volume loss.
yes, ma'am. Volume is present, and mediastinum should always be present in the midline, and the bronchial stump may also seen after the surgical removal of the patient with that also has a staples present at the removed site, ma'am.
What happens to trachea, mediastinum, and heart?
Usually they present a midline, ma'am.
No, it will be shifted towards the pneumonectomy. Towards pneumonectomy side, mediastinum, trachea, and heart will be shifted. And there will be absence of ribs also.
Yes, ma'am.
What are curly lines?
Curly lines were the air shadow. There are two types of curly lines, ma'am. Curly A lines and curly B lines. Curly A lines were the normal in the chest X-ray. Normal in the normal, ma'am, that were the repeated oblique lines that extend from the hilar towards the lobes, ma'am. These were due to some interstitial edema if present, ma'am. And curly B lines were most common, and these were the seen at the bases of the lung, ma'am, due near the costophrenic angle, and they represent the thickened interlobal septum, ma'am. And these were the these B lines were seen in the pulmonary edema patients if there is a fluid overload, ma'am.
Are there any C lines and D lines also in curly lines?
Yes, ma'am. There were C lines were there, ma'am. They are like a reticular web-like lines. They can present throughout the lower lungs, ma'am, and they represent the lymphatic drainage, ma'am. But they are very rarely seen on chest X-rays, ma'am.
Curly D lines also can be seen in lateral chest X-ray.
Yes, ma'am.
Hello.
Sir.
Amount of fluid to be accumulated to visible on X-ray chest.
X-ray chest is of about at least minimum 200 ml, sir.
Okay.
Yes, sir. That too, we can see that on a lateral decubitus and a lordosis position, sir. So that all the fluid is to be collected in the dependent position, sir.
Can you see right ventricle border also in the chest X-ray?
Normally, we don't see right ventricular border, ma'am, as the right ventricle, as it was obscured by the diaphragmatic part, ma'am.
Lateral X-ray, you can see right ventricle also.
Normal lateral we can see, ma'am, but PA view is PR AP view we cannot see, ma'am.
Any more questions from anyone? Any inputs? Any questions?
To diagnose fracture of ribs, which view you ask?
We usually go for AP view, sir, to diagnose any fractures, to see for any fractures, sir.
Oh.
How will you say cardiac on chest X-ray?
Ma'am?
How will you say patient have cardiomyopathy?
We use a PA view to assess the cardiac size, ma'am. We take the largest diameter of the heart, diameter of the heart, and take the diameter of the chest wall from of the thoracic cavity, and we divide thoracic cavity chest wall by cardiac border chest wall by thoracic cavity into 100, ma'am. If it is more than 50%, we diagnose it as a cardiomegaly, ma'am.
What are the changes seen in a mitral stenosis in X-ray? Ashok.
Sir,
What are the X-ray? You can see the mitral stenosis patients. What are the findings in X-ray?
There will be Stenosis. Okay. There will be a left atrium enlargement, sir, due to constant increased workload on the left atrium to push the blood into the left ventricle, sir. And also increased spacing between the carina, sir. And there will be a double density sign. That is the right border of the enlarged left atrium that pushes beyond the right atrium, sir. We usually term it as I think a shadow within shadow, sir. And splaying of the carina can also be seen, and left atrial appendage that we term it as a mogul or bump, sir, on the left heart border between pulmonary artery and left ventricle, sir.
Most important is that what you told is correct.
Pulmonary artery congestion, pulmonary venous congestion can also be seen, sir.
Yeah. Most
Due
important
to
is the left border is
like antler like
border. Most important. What you told is, and what is the mustache sign?
yes, sir. Antler sign is present on due to prominent pulmonary venous congestion, sir. Prominence of pulmonary veins, it looks like antlers. Deer antlers, sir.
And also you can able to see that.
So if it is a severe MS, there will be pulmonary artery hypertension can also present in this patient.
Calcified bonds.
Yes, sir.
Okay. All the best.
Thank you, sir.
Any more questions? If there are no further questions, shall we close the meeting? Thank you, Padmavati ma'am, JP Praveen sir, for your moderation, thoughtful moderation.
Thank you, sir.
And, thank you, Ashok, for the presentation.
Thank you for
The
this.
YouTube recording of the session will be available on our YouTube channel of the City Branch by next week. Thank you for participating in this postgraduate orientation and discussion. Thank you, one and all.
Thank you, sir.